Neal, we just concluded the 2022 AAMDS Scientific Symposium. I found it tremendous. What were your thoughts?
Yeah, so I think thoughts for the patients, but also thoughts for the conference. We really wanted to emphasize material experiments, clinical outcomes that were meaningful for patients. Some of those are really approximate, meaning that they're going to help patients right away, and others, basic research that's going to be beneficial to patients in a few years, we hope, not too long. I think the second point is that we really wanted to have young people who are interested in bone marrow failure and the related problems both organize the individual sessions and also be the major speakers and let the older or old people like us be the ones providing commentary, but give them the opportunity to lead it with their work and also with the conversation. The first day was really dedicated to mainly aplastic anemia, my area of interest, and I thought it was terrific on all counts. Most important for the patients is that there was a sort of implicit debate between those who really are favoring new types of transplants to be undertaken earlier in patients' courses, and the improvements in non-transplant therapy, particularly immunosuppression, the thrombopoietin or TPO agonists that have improved outcomes in patients who don't undertake a transplant. So that's a competition, but it's a good competition for patients. There are really two major modes of therapy that work extremely well, and most patients now can find effective treatment that prolongs life and cures a substantial proportion, a substantial majority of patients with aplastic anemia-related marrow failure conditions. That's very satisfying for us in the field, but most important for patients with disease.
Right, I found the notion of controlling inflammation a major theme of yesterday's meeting, both in terms of the inflammation that kills the bone marrow stem cells and causes aplastic anemia, and the inflammation that occurs when someone has the rare but sometimes devastating disease of paroxysmal nocturnal hemoglobinuria. And I don't know what your thoughts were, Neal, but I was amazed by the proliferation of therapies for this really rare disease.
Yeah, the old joke in the PNH community used to be that there were more people studying PNH than there were patients with PNH. And I think the new version is that there are more companies developing therapies for PNH than there are patients for PNH. It's a very interesting story in many respects why PNH has received this enormous attention, but there are a lot of new treatments either recently approved or which will be approved. And I think it's also remarkable, and I think for patients who have contributed to clinical studies by participating, it's really important to know that the sort of anti-complement therapies that were pioneered in PNH have been extended to so many other diseases. And we heard pipeline descriptions from some of our industry partners and supporters of the utility of anti-complement therapy in a broad spectrum of diseases that range now way outside of hematology to neurologic syndromes and others. And it's an example of the way I think medical science often works, that you start with a rare disease like PNH or aplastic anemia, and the discoveries, especially the discoveries in the clinic, are picked up and can be useful to so many more people. A really important reason to support rare disease research and to support basic research as well.
Exactly, and I think the basic research theme really played out this morning when we heard about some of the pathophysiological issues in myelodysplastic syndromes and how basic research can lead to therapies, both for the earliest sort of issue in MDS, the so-called clonal hematopoiesis, which is a relatively new entity where patients have mutations but don't yet have disease manifestations. But we heard an elegant talk about how preventing the inflammation that might promote the change from just the mutations to the actual disease might be useful. Another elegant talk about how working with the splicing mutations might be another way to have therapy in MDS. And I think the other thing, Neal, that really was very important to me this morning was the new prognostic classification systems and the new way to think about the molecular abnormalities in myelodysplastic syndrome that might both be able to be a way to measure outcome and predict outcome with and without therapy. So I think that's a great boon.
Yeah, very impressive. And again, from the patient perspective, important to know that some of these new prognostic categories, which I think are going to be more powerful than the historic, meaning going back just 5 or 6 years, that the new categories that will be codified by the various collaborative groups do come out first of huge numbers of patients who have contributed their blood and bone marrow samples, thousands in one of the studies that we heard this morning, more and more typical, and also the collaboration that's required. Collaboration obviously between patients and physicians, but among physicians dealing with myelodysplastic syndrome and other marrow failure syndromes all over the world. Really important, and it's really happening, so it's a really positive development.
You know, the willingness of patients to participate, obviously in clinical research where new therapies might be used that might help them directly, but also the willingness of patients to produce samples and allow their data to be used in these large collaborative efforts is absolutely required to move the field forward. And these prognostic categories, Neal, are not just tell me how I'm going to do, which is good, but people really want to know, can you fix anything that's not so good about how I'm going to do? And I think they will lead to more specific therapies, which we heard about this afternoon, in terms of promoting the ability of the immune system to eat MDS cells, using new therapies that can improve the sort of low-dose chemotherapy we have for MDS are very exciting. So I think we're improving prognosis. We're also improving therapy in MDS.
And discovery of therapies and how to use these drugs together. All good stuff that I think will translate pretty quickly into improvements in patient outcomes, even in MDS of the worst types.
Absolutely. So this was a very productive meeting, which will lead to, I think, benefit for patients. It was also very important to have a lot of the participants in person, which is great for interaction. It's also great to have people online. And ultimately, this is all about making things better for patients.
We also heard from a patient at dinner yesterday, and it, I think, grounded us all in just what we're doing all this for. It was a very heartening speech by one of our patients.
Absolutely.